This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.
Welcome to Wellness Update. My name is Sherry Plambeck. I'm the Director of Sales and Marketing at the Magnolia of Millbrae. We're a senior retirement community. We offer independent living and assisted living, and we're located in Millbrae, California. Our topic today is venous disease. Our guest is Dr. Gerald Sydorak. He is a clinical associate professor at UCSF and a practicing surgeon specializing in vascular and general surgery in San Mateo County. Welcome, Dr. Sydorak.
Thank you for having me.
It's our pleasure to have you here. Explain to me, Dr. Sydorak, what are veins and what are arteries?
Well, veins are blood vessels that bring blood back to the heart. Arteries are blood vessels that take oxygenated blood from the heart to supply and nourish the extremities and other organs in the body. So arteries are generally much thicker vessels, have greater elastic components, and are more powerful vessels. Veins are generally thinner vessels, and they return blood with the assistance of what are called as venous valves. And problems with these venous valves generally are the undercurrent of venous disease and its sequelae, namely related to venous hypertension.
Do you have a slide that you could show us of what a normal vein looks like?
Absolutely. Let's look at the first slide.
Okay.
We have a slide here of a normal vein and a normal, basically, valve cusp going from the lower extremity, and you can see the blood flowing up from the distal portion to the proximal portion. I believe if we look at the next slide, it will show, again, on the left side, you see the blood vessels or the blood cells going through basically a normal valve, and on the right side, you see an abnormal vein with abnormal valve cusps, which prevent the blood from circulating back normally towards the heart. And because of the abnormal valve cusp, the blood tends to pool in the lower extremity. And
so that's causing that in the middle there to project out?
Well, you can see the valve cusp need to come completely together. If you have an abnormal vein, an abnormal valve cusp, they don't come completely together. And as a result, with each step that you take, the blood, instead of going 100% back towards the heart, some of it tends to pool back in the lower extremity and cause the sequela of venous hypertension, which lead to many other problems and issues. And I think if we look at the next slide.
Let's look at vein anatomy.
Right. You can see the two pictures on the right depict normal superficial and deep veins in the lower extremity. And on the side with the topic or title, vein anatomy, again, you can see a normal vein with the three consequences of venous hypertension. The most common that people deal with are varicose veins, which are the largest veins. Then you can have abnormal veins known as reticular veins, which is a medium-sized vein, and the third type, the most superficial, which cause a lot of cosmetic deformity and concern in women, are the spider veins. Now, all these veins can cause problems and can be treated in a variety of fashions.
Now, those varicose veins, those are the type of veins that become knotted and they actually bulge on the leg?
The varicose veins themselves can get to be quite large and bulging and can cause a lot of venous stasis in the vein itself, which leads to increased viscosity and some trauma of the blood cells, and can develop into blood clots, which can not only cause inflammation in the veins, but can break off and produce pulmonary emboli to the lungs and heart, which can result in a variety of symptoms, including chest pain, shortness of breath, and potentially even death.
So are these veins painful for people then?
It varies. Usually with the larger veins, the varicose veins, because of the dilatation of those veins, the distension, there is a painful pressure phenomenon that the people develop during the course of the day, especially as they're standing on their feet. The smaller veins, the reticular veins, and the spider veins generally are more of a cosmetic consequence and sequela, but they can cause minor irritations. Most often people will complain of itching. Sometimes they will actually scratch these things because of the itching and can create inflammation and superficial infection.
So the first symptom of a person having this would be an itching feeling in the lower extremity?
With the spider veins, the most common complaint that the patient will generally present with are both a cosmetic deformity and some itching as they stand on their feet.
Well, as you know, in this day and age, style certainly changes for women, but women nowadays, very few are wearing hose. They tend to have the bare leg with a very high heel.
Correct. Well, I think it's essential for people to focus on taking care of their legs as much as they do on taking care of their face and their arms and the rest of their body. A lot of individuals have a tendency to neglect their legs and not treat them with the proper care that they deserve, and as a result, this can lead to problems, especially as one gets older. So I think it's very important for people early on to be cognizant of the fact that anything you can do to help the venous circulation will be beneficial in the long term. And I think if we go to the next slide, we can see one of the things that contribute to normal venous circulation. And here you can see a picture of superficial and deep veins. And the deep veins, which are very important in the venous circulation, are surrounded by muscles, which is known as the calf muscle pump. And as you walk, the muscles contract and actually help the venous circulation by pushing the blood along. So this is one of the things that the body does to help the venous circulation. But I think it's important for individuals, in addition to this, especially if they're on their feet a good portion of the day, and it doesn't matter whether you're standing or sitting, is to wear compression support stockings.
Let me ask you this. If a person has been a jogger or a runner, or say a young athlete, say a child has been a softball athlete, a baseball athlete, goes on to university, plays sports again, is that person more apt to have problems with their veins?
Well, it's interesting because actually an active person has two things in their favor. Number one, they have a more active calf muscle pump because their muscles are better developed, and they're using their muscles more actively when they jog or run. So from that perspective, it's a positive thing. On the negative side, there is trauma, especially with running. That's why I often tell patients that walking, especially rapid walking, provides as much cardiovascular benefit to most people, and you are not exposed to the trauma, which not only can to some degree adversely affect the veins, but can also cause orthopedic problems. The other thing is that for the spider veins themselves, the very tiny superficial veins, probably the trauma of running and jogging, especially if there is a hereditary predisposition, can actually increase the number of these spider veins and can cause more cosmetic concern to the individual. So in general, I would say it is beneficial to be active, but there is a small price to pay, especially in people who have a hereditary predisposition.
Now, what about the issue of spider veins then? Say a person has a great deal of pride, say a younger person, and they want to make sure that their legs look good all the time. What therapies can be done for that?
Well, the most common and quite successful is sclerotherapy. And sclerotherapy can consist of two approaches. One is injecting, usually in an office setting, a sclerosing type of solution through a very, very tiny needle, which is quite painless. I mean, occasionally people will complain of some very, very transient muscle
More like a pin
ache.
prick?
Like a very, very tiny pinprick. I'd say it's akin to diabetics who give themselves insulin injections. Most people don't even feel that type of discomfort, but some people obviously are a little more sensitive than others. The other thing you can do is called laser sclerotherapy, and the difference between the two primarily, I would say, is cost. We actually did a study where we did it primarily on, in our surgical group on our wives, where we treated one leg with the injections and the other leg with laser sclerotherapy. And after 6 weeks, there was really no significant difference. The benefits, I would say, were fairly equivalent. The downside of laser sclerotherapy is it's much more expensive because insurance generally does not cover sclerotherapy. They did many years ago, but I'd say for the last 15 to 20 years, they have considered a cosmetic procedure. And so it's something patients have to pay out of their pocket. And the cost of laser sclerotherapy is generally 2 to 3 times more expensive than the injection sclerotherapy.
Is this something that a vascular surgeon would do, or is it something a dermatologist would do, or a plastic surgeon? Whom would a person go to have this type of procedure done?
I would say all three specialties deal with this. In terms of cost, I hate to say it, but anytime you go to a plastic surgeon, things are always more expensive, perhaps because of their training and expertise on focusing on cosmetic issues. Anytime you deal with cosmetics, it's always more expensive. I do a fair amount of sclerotherapy myself, and I do it more as a service to my patients than as my primary practice pattern. So I think my prices perhaps are less expensive than that of most dermatologists and plastic surgeons. But in general, I'd say the majority of patients will get substantial cosmetic benefit from both injection and laser sclerotherapy. You can start with one, and if it doesn't work, you can revert to the other.
Now, once this procedure has been done, is that it then? It never needs to become an issue of having it done again, or do these spider veins come back?
Well, unfortunately, it's not so much that they come back as new ones develop. Sometimes they develop in areas where previous ones had existed, and very often new ones develop in other parts of the lower extremity. So I'd say the majority of patients that I deal with tend to come probably once a year, on occasion twice a year, to have touch-up sclerotherapy. If a patient doesn't get cosmetic benefits to their satisfaction, they generally will not come back. They will just focus on compression stockings and perhaps some skin creams. The other interesting thing is that men in general are not as concerned about the cosmetic aspect of it as women, and I've dealt with individuals, men individuals, who have had very significant evidence of superficial venous disease, and in general they deny that it bothers them. Perhaps they're a little more afraid of medical therapy at times, I think, because I find in general men don't come from medical care until at a much later stage in the disease process than women.
Well, they do say women are the stronger sex, so I don't know. There might be some theory to that. Tell me, if those spider veins are in the lower leg, is that less detrimental than having the spider veins in the upper leg, or is it the same?
I think the difference is that the spider veins in the lower leg below the knee are generally associated with other sequelae of venous hypertension. And this has to do with basically that when venous hypertension occurs because of a combination of the incompetent valves, which we pointed out, also perhaps the fact that some people stand on their feet much more than others without using any kind of compression support. And the third potential could be that some people are just heavier than others, and obesity plays a role in the gravity because we're basically a bipedal organism. We tend to be on our feet, even though genetically they say we were crawlers, which was healthier for our feet in general. But in general, you can have skin changes in the lower extremity from the hypertension, and this usually has to do with blood cells transitating through the veins into the surrounding fatty tissue. And when it does that, in combination with the increased venous pressure, these cells burst, and they contain a pigment called hemosiderin, which stains or tattoos the tissues and causes, in addition to the superficial veins, the spider veins or the reticular veins, it causes an actual pigmentation.
So is that pigmentation like a reddy brown?
Right. It's generally a brawny brown. It can begin as a fairly spotty type of presentation, but then it tends to coalesce, and these areas, because of the changes in the fatty tissue, tend to develop thinned out and weakened skin, generally occurring on the medial aspect of the lower leg and ankle. And as a result, it's very important in people who notice these changes to be very careful and avoid any trauma to these areas, because they have an increased potential for developing venous ulcers, which is one of the significant sequelae of venous hypertension and venous disease.
And that venous ulcer can actually start from a spider vein that just keeps bursting and bursting?
Generally, it's not from a spider vein. Spider veins are very, very superficial and are more, as I mentioned, of a cosmetic issue. Usually, the venous ulcers develop in areas of actual varicose veins associated with venous hypertension.
Now, a varicose vein, if you have varicose veins, that's not a disease condition that's really going to kill anybody immediately. It's something that can be addressed and with different therapies can be kept under good control for a person's lifetime.
Yes, varicose veins, if they're asymptomatic, generally can be controlled with a combination of compression stockings. They can also be treated just like the spider veins with sclerotherapy. The sclerotherapy with varicose veins, the larger varicose veins that we're talking about, will shrink these veins and will improve the symptoms. And the symptoms are generally like an aching, pressure, discomfort.
Would that be all day long that a person would have that feeling of aching discomfort?
It usually gets worse as the day wears on because the pressure increases, especially if you don't wear support stockings. The pressure does increase as the day goes on. But the varicose veins generally can be treated, like I said, with less than surgery. In the old days, there was a lot of stripping of veins that surgeons would do, where they would actually make incisions and using certain instruments sort of avulse these veins, which sounds somewhat brutal.
So the vein would actually come right out then?
The vein would actually come out. It would also cause some trauma to the tissues underneath the skin. Sometimes there'd be some bleeding, and it might take a couple of months for all the bruising to go away, but it was effective. Now there are, you might say, gentler methods of treating these varicosities using, again, a combination of percutaneous wires and catheters that are put especially in the main vein on the medial side of the lower leg that extends from the ankle to the groin. And the vein can be ablated using a form of thermal energy. And one form is called radiofrequency. The other form is a laser form of energy.
Is that a serious procedure to have done?
No, it's actually an outpatient procedure. It can be done in the hospital on an outpatient basis. There are people who do it in an office setting as well. The only downside that I see from my many years of experience is that your main vein, the greater saphenous vein, is a major conduit that is used as one gets older and develops cardiac disease or peripheral vascular arterial disease, is the main conduit and the best conduit that's used for bypass procedures. When people actually have open heart bypass surgery, you can use one artery in the chest for the bypass, but generally people have between 3 to 5 bypasses, and the other bypasses are performed using lower leg extremity veins, which incidentally are of somewhat better quality than upper arm veins, which can also be used. If you have these veins either stripped or ablated, then you no longer have these available for the bypasses. So
if this happens to you later on in life.
Exactly.
Or even at a very young age, too.
Exactly. So it's very important. I think a lot of women, young women, focus more on cosmetics, and they don't think of the potential consequence of losing these veins, and they don't realize that once these veins are gone or ablated, they're no longer available for later on in life should they need it. So I always emphasize to my patients when they come to me and ask if I would consider doing this procedure on them, I always ask them about their family history and is there a significant family history of cardiac disease, because most people, especially when they're young, they don't focus on their heredity and their genetics.
No, they're too busy thinking of other things.
Other things, absolutely. And family history, I think, is very, very important for a variety of diseases, and that includes venous disease and heart disease. And all that needs to be taken into consideration.
So would you recommend for a younger person then not to have that procedure done, to have those veins stripped like that?
My general recommendation for younger women is to try a sclerotherapy on the veins that bother them. And I find a significant portion of the women are satisfied with the results of the sclerotherapy. If the veins are obviously humongous, and on occasion, I think if we look at the next slide, if that's possible, we can see the again, the venous circulation of the ankle and lower leg. And I believe what this shows are some of the components of venous circulation that contribute to the development of not only venous hypertension, but potentially large varicose veins. There are a number of perforators. There are 3 in the ankle area. There is 1 below the knee and 2 above the knee. And if these perforators, which are communicating veins between the deep and the superficial veins, are incompetent, and there's incompetence, valvular disease in the deep veins, that high pressure is transmitted to the superficial veins through these perforators. And if the perforators, in addition to the deep veins, are incompetent, that adds insult to injury. So sometimes these people will tend to develop very large varicose veins. And if the varicose veins are very large and symptomatic, then I think the probability that they could be used for bypass surgery later in life is low, and these people would need some form of more aggressive surgical therapy, such as a combination of ablation, either radiofrequency and laser, or in addition to that, what's called stab phlebectomies, where some of the large varicose veins are actually removed surgically using like the equivalent of a crochet hook through very tiny stab wounds, which are almost indistinguishable post-operatively from a cosmetic standpoint.
So is it worse to have the varicose vein in the lower leg or in the upper leg?
Well, generally these veins are contiguous. So they're more common in the lower leg simply because, as I mentioned, the venous pressure and the venous hypertension is worse in the lower leg below the knee, and especially at the ankle, than it is in the upper leg. But some individuals and some women tend to have abnormal venous collaterals in the thigh with an essentially competent greater saphenous or main superficial saphenous veins. So these people can develop more prominent varicosities in the thigh and minimal to smaller varicosities in the lower leg. But in general, the lower you go in the extremity, the higher the pressure and the more prominent the varicosities. I think if we go to the next slide, it shows one of the unfortunate sequelae that occur with venous disease, and I think we mentioned this previously, and this comes from a combination of both incompetent valves, stasis changes, and potentially trauma to the lower leg. As you can see on the left side, you can see blood flowing through the valve in the vein. And what happens with a combination of stasis, trauma, and standing on your legs a lot without any kind of compression, that these blood cells can clump together and form blood clots. And this results in both an inflammation in the vein, and also because of the inflammation results in a destruction of the normal valve. So the valve becomes chronically incompetent, and this can lead to either a breakage of the clot that goes up into the heart and lungs, or it can also result in what's called post-thrombotic edema, where these people develop like a chronic swelling of their lower extremities with inflammatory signs. And it's essential for people who develop leg swelling and pain to have a test called the Venous duplex scan, which is an ultrasound study of the veins, and this will show not only whether you have valvular incompetence of your deep and superficial veins, but it also will show whether there are any blood clots, because if you do have blood clots, especially in the deep veins, then you need to be treated with anticoagulation for a minimum of 3 to possibly 6 months to both prevent blood clots from going up into the lungs and to minimize the inflammatory sequela of deep venous thrombosis.
So if you use that anticoagulant for, say, 6 months, and then everything is presumed to be back to normal, can a person get off of that therapeutic regimen?
That's a good question, because different strokes for different folks, you might say. The majority of people will have complete resolution of the blood clot on the anticoagulant without any clots going up into the lungs and heart. Some people, probably because of the inflammatory response that's associated with the blood clots, will have destruction of the valves to such a degree that they develop chronic venous incompetence and what's called chronic lymphedema, which is like a chronic swelling of the lower extremity. And it can be quite significant, especially if it's associated with people who might be additionally on the obese side and who are perhaps sedentary or on their feet and don't really take good care of their lower extremity. One of the things that I recommend to my patients generally is, in an effort to help your legs, both from a standpoint of wearing support stockings, you should spend about 20 to 30 minutes every evening watching your favorite news program or sitcom program and lie down on the floor or a mat and put your legs so they're higher than your heart. So you totally empty your legs and basically you give them a break, you give them a rest, which they don't get most of the time.
No, unfortunately, I think people are very busy during the course of the day. Sometimes they're busy with their fingers too, because they're too much on electronic devices as well. Dr. Sydorak, thank you so much for taking the time to come to visit with us today. We sincerely appreciate it, and also thank you for explaining in a little more depth for us to understand what venous disease is really all about. And I think as we all need to keep in mind, we're so cognizant of our face and our upper arms, and certainly hair is a big issue for many people as well. But I think we also need to focus on our legs and our lower limbs and trying to do the very best that we can for them in rest. And who couldn't do with relaxing, elevating your legs at night and watching your favorite TV sitcom. So thank you so much. Live each day. Life is so very, very precious. And thank you for allowing us into your homes today. Bye-bye.
This program was made possible with the generous support of the Magnolia of Millbrae. The Magnolia of Millbrae is a senior living community that provides a variety of services and amenities to its residents. For more information, call 650-697-7000 or visit their website at www.themagnolia.com. MCTV thanks them for their support.